Good morning and good afternoon, everyone. Welcome back to the DASH webinar series. My name is Carissa Novak, and I am a program manager at the Harvard Global Health Institute. I'm excited to welcome you here today for what is our first webinar in the new DASH webinar series, How COVID-19 is Changing the Digital Health Space. This webinar is part of a new 4-part virtual event series co-hosted by the Novartis Foundation on the intersection of AI, COVID-19, and low resource settings. It builds off a previous 8-part series we hosted in the spring and summer as part of the Data Science and AI Summits for Healthcare. On Thursday, November 12th, we will have our second webinar entitled Sustainable Business Models for AI in Health. For more information on this webinar and others, including recordings of past webinars, please visit us at dashinafrica.org. In today's webinar, we bring together panelists with a diverse range of expertise in AI and data science to collectively think on why we are seeing an increase in the use of digital during the COVID-19 pandemic, and how this crisis has awakened the world to the crucial infrastructure that needs to be in place to respond rapidly to future health emergencies. Before we get started, I have just a few housekeeping notes. This video is being live streamed through Zoom, Facebook Live, and the recording will be made available on the DASH website afterwards. We will be running a live Q&A towards the end of the webinar, so we have enabled our Ask a Question feature at the bottom of your screen. If you have any questions during the webinar, just pop it there and we'll do our best to answer them during the Q&A portion. We have also enabled the chat function, which will be monitored and overseen by my colleague, Luke. When using this function, please make sure you set the message recipient as everyone and not just the panelists. To get us started, we would like to invite all our participants to use the chat functionality to let us know where you are connecting from today, including the city and country. I am calling in from just north of Boston, Massachusetts. With that, let me introduce you to our speakers today. Dr. Maya Majumdar is a member of the ladder rank faculty at the Computational Health Informatics program based out of the Harvard Medical School and Boston Children's Hospital, and is a recent graduate of the Engineering Systems program at MIT's Institute for Data, Systems, and Society. Her current research interests involve probabilistic modeling, data science, and systems epidemiology in the context of public health, with a focus on machine learning for infectious disease surveillance using digital disease data, like social media and search trends. She also enjoys exploring novel techniques for data procurement, writing about data for the general public, and creating meaningful data visualizations. Since January 2020, Maya has been engaged in pandemic response efforts and is a leading expert in COVID-19 epidemiology. Dr. Helmy Zachariah is the Chief Executive Officer for Artificial Intelligence in Medical Epidemiology, where he leads the delivery of data analytics solutions in public health, women and reproductive health, and sustainable agriculture across 3 continents. In November 2019, Dr. Helmy Zachariah was appointed as a member of the WHO ITU Working Group for AI and Outbreak, a multi-institutional and global platform that aims to leverage machine learning to mitigate outbreaks. When the COVID-19 pandemic reached Malaysia, he was tasked to lead the digital epidemiology portfolio for the Selangor State Task Force for COVID-19, the most densely populated state in Malaysia, where he pioneered the nation's first QR-based e-tracing ecosystem, which was then replicated nationwide. Akona Tangela is a program manager at Africa Center for Disease Control and Prevention and joined Africa CDC as one of the first staff members. Her main role is to manage the mortality surveillance program, in which she is responsible for designing and executing the program's strategy for understanding the numbers and causes of death in African countries, and improving the use of this data for decision-making. For their COVID-19 response, she chairs the Sciences, Regulations, and Standards Technical Working Group under the Africa Task Force on Coronavirus. She also leads the knowledge management platform's innovation and research for the COVID-19 response and is part of the steering committee for the COVID-19 Clinical Research Coalition. And lastly, our moderator, Bruno Villatelle, is the head of data and digital global drug development at the Novartis Foundation. He drives GDD's data and digital vision, strategy, and governance, and is focused on embedding data science and digital technologies to enhance asset development. Bruno has more than 30 years of experience spearheading digital and technology-led innovation and new business model creation in the pharmaceutical, consumer health, and service industries. With that, I will hand the mic over to Bruno, who will be leading the discussion.
Great. Thanks so much, Carissa, and warm welcome to the many participants to today's webinar. We have a great lineup of panelists, as Carissa just shared with us. And today, I hope we will have an insightful discussion around how COVID-19 is shaping the digital health space. I will ask our esteemed panelists to give us some concrete examples on how this extreme experience has awakened the world, why they're seeing an increase in the use of data and digital during the COVID-19 period, and what ways this rapid spread could act as a catalyst for a new normal, a different future. So we have quite a heavy agenda. I'm not going to make it any longer. I'm going to first invite our three panelists to give some intro remarks, complementary to the introduction Carissa just made, right? And then we will go through questions and answers, including your questions through the chat. So without any further ado, let me hand over the mic to Akona. Akona, please share with us your initial thoughts.
Sure, thank you, Bruno, and thank you very much to the DASH team for inviting me to. Good afternoon, good morning, and good evening to all of you. So as Carissa pointed out, I am Akona Changela, and the reason why Africa CDC has been basically mandated by all African Union member states within Africa to help them in responding to outbreaks and public health events. And in terms of digital health, our key role really has been monitoring the public health and social measures that have been implemented within the continent. As you may recall, Africa probably was one of the first continents who actually went into lockdowns even before having cases in some parts of the continent. And so we've basically over a couple of months helped monitor these public health and social measures as the cases have changed and evolved over time, as the pandemic has evolved, to try and see how we can support the member states. We use social media, we use official communication from our member states to try and do this. On top of that, though, we've just recently started rolling up the Africa CDC Trusted Travel Portal, which basically tracks pre-entry and exit requirements of all the African Union member states, which allows travelers to be able to see as well which of the trusted labs they can actually use before traveling to get their COVID-19 tests conducted, and also upload it on the digital platform to be able to share it with the country that they are going to. And essentially, I won't take too long. Please feel free to visit our website. We're Centers for Disease Control and Prevention, and we do many other things in response to the pandemic. And I'll just end there with my introduction. Thank you, Bruno.
Excellent, thank you, Akona. And maybe you want to mention or include the address of the website into the chat so that our participants can easily get access to it. Let's move to our second panelist today, Helmi. Back to you for your initial thoughts, kind of self-intro.
Well, hi everyone. I'm Helmi Zakaria from AMI. That stands for AI in Medical Epidemiology, and I'm calling in from Kuala Lumpur, Malaysia. So what we do over here is that we leverage on big data and machine learning for epidemiology so that public health decisions can be made timely and responsively. And our niche is in population health, not really on personalized health. And we previously focused on dengue, Zika, non-communicable disease, and women's health. And we deployed across Southeast Asia and the Caribbean. In practice, though, our approach and how does it differ is that it combines both health and non-health data points, such as weather, urban design, physical build, social viscosity, and etc., to predict the occurrence of outbreak in advance so that resource allocation can be made more strategically. It also means that when the COVID-19 pandemic hit Malaysia, we had to be at the forefront, providing data and insights to coordinate the state government response. And in short, for COVID-19, we operate on two solutions. The first one is a cluster prediction platform, where we predict the trajectory of COVID-19 cluster using what we call as inherent risk of contagion modeling. If you ask me, it's just a fancy word to say that we focus more to measure population vulnerability rather than the more conservative approach of measuring case number. And when we do this, we are able to deploy active case detection strategy and to prioritize our limited health resource. And our second solution was that we built in a citizen-driven, crowd, community-based, and very based contact tracing platform. And while initially it was used for the purpose of contact tracing, now it have evolved into a multifunction ecosystem that have been used for overcrowding surveillance. It have been used for SOP compliance monitoring, and also for rapid welfare allocation and distribution. Yeah, so I think that would be my short introduction for now.
Great, thank you, Elmi. And last but not least, Maya, back to you for some initial reflections, please. Maya?
Great. Hi, everyone. I am calling in from Boston, Massachusetts. And as Carissa was kind enough to introduce me as, I am a faculty member at the Computational Health Informatics program at Harvard and Boston Children's Hospital, where I am a computational epidemiology faculty member. And I specialize in using digital data streams like news media, social media, and internet search query data to study public health problems. So my research group uses machine learning techniques like natural language processing to understand the role of news and social media on the way that the public perceives different public health problems, autoregressive models using search query data to understand what symptoms and behaviors individuals are searching for and engaging in response to outbreaks, and agent-based models to understand the impact of interventions on disease transmission. So I've been using these data sources since the 2013-2016 Ebola epidemic in West Africa. And since then, I've also responded to the Zika pandemic in 2015-2016. And domestically here, I've also done quite a bit of response work with vaccine preventable illnesses like measles and mumps, which are resurging due to vaccine hesitancy here in the United States. With each passing day, these data streams and others like it become more representative and robust, which has been a huge asset during the ongoing pandemic. Most of my work on COVID so far has been domestic, but I started work with my colleagues at Google Research India a few months ago, and I've become particularly interested in Google's mobility data, which can lend insights into compliance with non-pharmaceutical interventions such as social distancing and sheltering in place, and the possible effects therein on transmission. Beyond my early work in tracking transmission in India, my team has been conducting research into the relationship between mobility as a proxy indicator for compliance with non-pharmaceutical interventions and democracy around the world, with a focus on trust in governance and institutions as a possible conduit for whether or not individuals feel that they can or should comply with non-pharmaceutical interventions. We couldn't answer these kinds of questions until pretty recently, given the pervasiveness of smartphones worldwide and across unprecedented class divides. But despite the great utility of these data, they're also vulnerable to privacy and security issues that both domestic and international legal frameworks have yet to fully address. So I would ask personally that our audience keep these issues in mind throughout our discussion today. Thanks a ton.
Great. So thanks to the three of you for the introduction. Let's jump into our fireside chat. And maybe Maya, I would propose that I stay with you for first question, which is, would you agree that we are seeing a radical increase in the use of data, digital and AI, including in the low and medium income countries during the pandemic? And if so, what is for you the main reason? You talked about Ebola, you talked about Zika, you've been involved in other pandemics. What would be the main reason of this acceleration?
Right. So I think that smartphone penetration is a really, really big factor in why digital epidemiology has become such an important part of the way that we're responding to the current pandemic. And I think that this is true worldwide. So there are some fantastic statistics from many think tanks around the world that track this kind of statistic. And the reality is that with every day, more people have access to the internet and from more corners of around the world. And I think that that's particularly important because I would say even 5 years ago, and certainly 10 years ago, this idea that you could use internet or World Wide Web based data to understand population dynamics during a public health crisis, that idea was, I think, still a germ of an idea for many parts of the world, where you could really get quite a bit of insight into areas like the United States, where there was already fairly good internet coverage. But I think that that's changed drastically in the last 10 years, where we're now starting to see immense internet coverage all around the world. And that, as I mentioned in my intro, this really does cross a lot of unexpected class divides. And I think that that's really helped us get a more representative picture of what's going on. Now, that said, I think that representativeness is still a really huge problem. And I think unless you get to 100%, you're still going to have your last however many percent, it's, depending on the country, it's 10%, 20% that you are still kind of missing with these sorts of data streams. But on the other side, there's also the techniques that we've developed to analyze these sorts of data and other sorts of data that are massive in scale. And that would include artificial intelligence techniques, machine learning techniques, like the ones that I mentioned. And I think that the biggest asset in the development of these methods has been our increase in computing power worldwide. I think that one of the things that's been particularly amazing, and this is something that I realized when I was working abroad before the pandemic began, is that now you can access clusters for high power computing from almost anywhere around the world because of the advent of things like VPNs. And this is something that is still relatively novel. The power that we have with which to compute is still relatively novel. So I think that this idea that we both have advances in the way that we're collecting these sorts of digital data streams, but also the way that we're analyzing these digital data streams are both really important considerations that I think are working to the benefit of the pandemic right now in terms of better understanding some of the lingering questions that we have about the way that populations, especially and individuals, respond in the face of a crisis.
Great, thanks, Maya. Maybe Akuna, same question to you. Very impressed in your intro when you talked about the work you're doing with and on behalf of all the members of the African Union across the countries. So same question to you. Would you agree that we've seen a surge and acceleration of the use of data, digital and AI, and for you, what are the main reason or the main reasons?
So for Africa, I just want to go back to one of the comments that Maya made in terms of representativeness. In Africa, I think we need to really keep in mind that based on stats from 2018, only 23% of the African population have access to actual internet. And then we're expecting probably by 2025 to have 60% penetration in 3G. And so I would say that uptake within the region has been relatively slower comparatively to the rest of the globe. But we are definitely seeing a quick uptake, and platforms that have already been developed and been implemented for other programs being repurposed and being used for the COVID-19 response. And so I think we are starting to see the light, things that have fit our ecosystem within the African continent, such as Mom Connect using USSDN, have really taken up roots in order to be able to share that relative information with regard to COVID-19, to be able to minimize misinformation. And so I think we still have a long way to go in terms of digital health within the African context. But I think definitely COVID-19 has been that catalyst in the sense that in helping and ensuring that we shift from in-person diagnosis and also start thinking about virtual platforms that can freely access rural areas that have less access to healthcare. And so I think really, I would hope that our leaders are starting to really think through on investments in ICT infrastructure and also building the necessary capacity within the continent to start making sure these are built up.
Thank you, Akuna. Great different lenses and viewpoints. And Elmi, I would love to ask you to reflect a bit on this kind of different viewpoints that both Maya and Akuna shared now. And I would love to ask you, what is your viewpoint about the key success factors in localizing a successful way to address the challenges of the COVID-19 pandemic, right? From high-income countries to low and medium-income countries, or the other way around, right? Any views on this, Elmi?
All right. So I think before I jump into that, I would like to answer that with this one broad covering statement, right? And I can only answer it from the perspective of digital epidemiology, because that is basically the field that I'm operating in, right? So when it comes to epidemiology, there are some, when it comes in the intersection between digital data and using AI and machine learning with a more conservative epidemiology, there's a little bit of a trade-off that we have to take into account. Like, for example, there are some methods that are immediate, not 100% epidemiological. And also, on the other hand, there are others that are more directly epidemiological, but at the same time, more a bit out of date, right? And unfortunately, for low and middle income country, we don't really have a high investment being focused on epidemic. So, for example, in Malaysia, you do have West Malaysia and East Malaysia, just as the map behind me, and it become very evident that most of the epidemiologies are only concentrated in a certain area. And this actually is a new solution that need to be rapidly escalate in setting us. So this is how the field of digital epidemiology that have been put a little bit advanced than what it was previous to be. So, for example, previously the work in digital epic usually were to build on or confirm on the findings of what was already known in the past. For example, in dengue. So, in terms of COVID-19, though, as science cross discipline are still racing to uncover new insight. And because of the limited number of epidemiologists that we have in Malaysia, then practitioners like myself, we have been pushed at the forefront and in parallel with other disciplines, because it then become a crucial platform to merge multifaceted insights and findings into one holistic, actionable plan that is urgently required for policymakers and program managers. So that is one of the nuance when it comes to digital epidemiology in low and middle income setting. Now, we talk about approach, but one of the biggest challenge place like Malaysia is when it comes to data acquisition. Yeah, there's a lot of privacy concern when it comes to content example. And likewise, when we try to get patient data or case data, usually health program managers can sometimes be at odds on how much case or how much patient data they can disclose, even without revealing a personally identifiable variable, right? So we had to then leverage on something that is more rapid, which is basically crowdsourcing citizen data. And when we have a direct communication with citizen, we ask them and we basically plead to them that, hey, if you were to crowdsource and if you were to contribute this data lake, then we probably can handle the pandemic more efficiently. And even for people who have been infected with COVID-19 before, if you were to ask this set from institution, from the hospital, usually it's very difficult. But when you reach to the patient themselves through this platform, usually people are more willing to share than what you might initially. So that is one thing, though. But at the same time, because in order for us to deploy this community-driven platform, you need support from multiple stakeholders. The business model that you come up with must be something that is acceptable to everyone. And there are some key factors that I found out can guide us, and also from my previous work in dengue. So number one, though, like for example, cost. In low and middle income country, you cannot run away from cost. The cheaper it is, the easier it is to be deployed, then the more uptake that you'll be able to see. In our case, because the deployment really depends on the business community and public space administrator, so the cost for business to participate and to adopt the solution must be really, really low. So in our case, when we thought that it is about a QR-based contact tracing, in reality, the cost for business to participate into the ecosystem is basically just register and printing one A4 poster with a unique QR code representing their space. We also found that we have to consider opportunity cost as well, whether in deploying such solution, it will take away from their main reason, which is to basically to conduct commerce. So it has to be balanced on both. The second thing is the commonality, right? So when we come up and when we look into the many modalities of contact tracing, we found out that the technology that are to be deployed in the local community must be something that is very familiar with them. So I know this Bluetooth technology spoken, especially in a more modern world. But if you speak about Bluetooth in Malaysia, like literally no one is using it except for the purpose of these earbuds. And people don't necessarily switch on their Bluetooth all the time. So we know that the kind of thing that we are going to deploy must be something very, very familiar to the society. The community, that when you come up with this solution, there must be a sense of participation and ownership, as opposed that it is being imposed upon. And that is why we deploy it, we first run it as a crowdsourced and a citizen model before it later on being adopted by the government and it being made official. And lastly, I think the conduct of the business model. There's still a lot of, I think, skepticism when it comes to contact tracing. So of the model must initially be scientific, inclusive, and public-oriented. And any divergence from it being inclusive will prove counterproductive. One of the examples that I can share is that after our business model was being taken up by the government, and unfortunately in some state of the government, rather than it being used for an SOP compliance monitoring, it's being used more of a way of an avenue to how do I say, to basically come out with a punitive method for people who are not complying with the SOP. And that was unfortunate because after that, we saw like there was a drastic drop of population uptake on the solution. Yeah.
Great, thank you, Elmi. Very comprehensive. Maya, you mentioned that you had experience across the countries, different ecosystem. Any perspective on this same question? Key success factors in localizing business model of COVID-19 solution across low, medium income to high income countries?
I think a lot of my opinions reflect Helmi's. I do think that keeping the local context in mind is enormously important. And this, I think, gets back to what Akona was saying a little bit earlier, where we have a lot of heterogeneity worldwide in terms of access to different resources. And so for me, this is something that, it's very important to kind of keep an eye on this because the last mile varies so much from location to location. And who comprises the last mile varies a lot from location to location. So Akona highlighted the African continent, and I think that that was a really excellent example of this. And one of the things that I like to think about a lot is that in 2010, something like 30% of the world had internet access. And now that number has almost doubled. And I think that that's really something to keep in mind, in a decade to go such lengths to bring internet access to different corners of the world is quite impressive. But I think at the same time, when we're thinking about how do we translate solutions that work, for example, say in high income countries to low and middle income countries, I do think that this idea of how do you tailor these interventions so they work better in the given context that you have is essential. And I really liked Helmi's example of the QR codes, especially because I think that QR codes, this is actually an example of where many low and middle income countries have done a better job of this, of implementing this than high income countries have. So I think that it goes the other way around as well. And contact tracing, digital contact tracing has been an immense issue in the United States because we have major privacy and security issues associated with mobile phone data here. And I think that as a result, compliance has been abysmal. And as a result, we can't use the data that are being collected by the very many digital contact tracing platforms that have emerged here. And one of the things that I've personally been pushing for and have often cited Malaysia as a success story in this regard is the use of QR codes as a way to help curb some of these concerns, because it does drastically reduce the amount of risk that is incurred by the user. But even beyond that, I think there are lots of ways to make QR codes more accessible to folks who don't have smartphones either, which is really cool as well, where you can use text-based and voice-based QR code systems as well now, which is really incredible. And that means that folks who don't have smartphones but have a lower tech cell phone can comply with these sorts of solutions. So I guess I just want to highlight that, where I think it does go both ways. I think that there are really innovative solutions that are coming out of low and middle income countries that would be astoundingly useful in high income countries as well, because some of the concerns and some of the constraints are the same. So in the US, we have 10% of our population that doesn't have access to a regular use smartphone. And so that really means that, or regular use internet. And so what that really means is that we do still have a pretty considerable portion of our population that can't engage in a lot of the interventions that we're proposing here. So I think that's another thing to think about as well, where even in high income countries, we have heterogeneity here as well that is really important to consider. And we have to think about who are we excluding when we implement a certain intervention, and what are the things that we can learn from low and middle income countries to help reach that last mile here especially. So I think I'll just stop there, but I really enjoyed what Helmi had to say about that. I thought that was great.
Excellent. Thanks both Elmi and Maya for this. I would love to build upon your response and move to another aspect, which is, and the question that was asked online by a couple of participants around the potential biases or potential misinformation associated with using an increasing a number of digital sources. I don't know, maybe Alcona, you want to start with this? So any view on this risk of biases with digital stream of data and or misinformation?
Yeah, definitely. Because if you think about it, the Google mobility platform, for example, we look at that data and it's not very representative of the whole of the continent. However, we use the data to be the one to tell us whether people are moving less, are adhering to the social distancing measures, etc. However, it's very difficult to say this is general representativeness. And I just would like to say to most people, to most tech companies, when they think about doing a platform, especially in low middle income countries, they need to really fully understand the ecosystem that they are working in. Like Helma pointed out, Bluetooth, we only use it for earphones and those who can afford a Bluetooth earphone. And so measuring mobility in a rural area, for example, where Google doesn't even far-reaching and where more than 50% of the continent lives in a rural area, it really does create some form of a bias in that respect. So we find that sometimes the measures that we make in response to the COVID-19 pandemic, although we need to rely on that information, it are biased because of the limited information that we have. And we have a challenge in terms of data sharing on the continent. And so member states are not that much willing to share the data. And I think both Helma and Maya pointed this out because of the privacy and security issues that need to be addressed before we can actually jumpstart and say, well, we need to go into full-on digital health. What about the privacy of the citizens? What about the privacy and the sovereignty of the member states? And so these are key considerations that we need to think about when we are trying to implement digital platforms. And strong collaborations. I think Helma mentioned it as well, and Maya mentioned as well. You cannot come into member states and just come with your own tech and thinking that you can roll it out, because then you need to build that trust with the country itself, as well as with the community that you're going to be working on. And so we do see little pilots here and there of digital platforms, but then we need to think, are they scalable? How many of these are actually flexible enough to be moved from a program like maternal health to actually supporting the response to COVID-19? Are these sustainable? Because then there are cost implications that we need to think about when we're talking about low middle income countries. And interoperability, that's one of probably the most important things. These streams, are they interoperable? For me, if I'm a government agent, where I can just capture my data and it will go out to all of these different streams without me having to worry about having to recapture in all the different streams. And so I think for us to really think about the success of these platforms, we need to think about all throughout those lines to really fully understand and be able to circumvent any of the biases that may arise due to digital health.
Great, thank you. No, can't agree more. We had more questions about this this risk and how you panelists you assess the risk of biases and misinformation. So if you don't mind, I would love to get Elmi and Maya's feedback on that. Elmi, first, maybe some perspective from your standpoint. Same question: biases, risk of misinformation.
Yeah. Well, first things first, though, when we deploy the QR-based contact tracing mechanism, just like Maya point out in advance, like there are a pocket of people who are not using smartphone regularly, and this is basically one of our early blind spot, and especially when it comes to Malaysia, it was among the migrant and foreign workers. And one of the way that we have closed that gap is, like you said, Maya, like we have played to the telco company, whether they can provide us with a SMS gateway so that people can check in using SMS. And when people can check in using that, it actually increased the uptake by an extra 70%. And this actually goes in line with the proportion of people who are not using smartphone in Malaysia. And on top of that, there are also like that small group of population who just wouldn't be able to use that and more prefer a manual form. And this is basically what we did, and it was something from my previous agriculture project. So in agriculture project, a lot of data that being key is usually in the written form. And if you ever have to pass through the border migration authority, you have to fill in your landing card that it have all these little square and whatnot. So basically what we did, we just produced a standardized printable form on the website, and we are telling all the shop owners and whatnot, hey, if for example some elderly people who are not used to using phone and they are still keen on writing in their name and whatnot, just use this standardized form, because from that standardized form, then we have a certain technology that those forms can immediately be digitized if they were to send it by email, example. So that is one way we try to close the gap. On another hand, we also quite cognizant of the fact that in some place there are simply no good internet connectivity, and we're quite good. What we have done, libraries and whatnot across Malaysia was closed during the lockdown. What we did is we mobilized all of these bus with Wi-Fi internet connectivity that was previously in the community library, and then we move it to the what Maya said was the last mile community. It was just in order to see like, hey, if we were to deploy it here, like whether there will be a high uptake. And actually we've seen that, and one of the positive effects we are able to see is that actually there are a couple of telco companies now putting up a resource together to say like, hey, we should build up a telco tower here. So that is one of the positive outcome that we see from moving around the resource into the gap. Yeah.
Oh, that's fascinating. Fascinating. Thank you. How those solutions can become more long-term evolution and accelerators. We might come back to that if we have time later on in the panel. Maya, any additional thoughts on this question of biases, misinformation?
Yeah, so I'll chime in actually from the kind of statistical and probabilistic point of view, because that's where my background is. And I think that one of the things that we need to recall whenever you use a given source of data, there will be biases attached to these data. And there are absolutely methods that have been developed over the course of hundreds of years to help address these biases. So sensitivity analyses are probably the most common way to deal with this, and I use them all the time, mostly because I am fully aware of the fact that depending on where I am doing my research, I may really be only capturing a small fraction of the population, and that fraction is not particularly representative, as Akona pointed out. So I think that when you have these kinds of situations, it becomes really important to learn the mechanism through which the data are collected. So when you are aware of the conditions that are required to collect these data, so say, for example, to collect mobility data from Google, you need to have a certain set of conditions met. The people need to have smartphones, the smartphones have to have GPS enabled, and these are both conditions that have probabilities associated with them. So when we start to think about this as a mathematical problem, we can start to understand then, so what percentage of the population does this actually represent? And so from beyond that, what happens if what we're seeing in this population is not fully representative of the rest of the population? And I think this is where really thinking hard about how other disciplines have started to learn how to use these sorts of techniques for other disciplines entirely. So I think that these sorts of biases are also very pervasive in other disciplines. Marketing and advertising are perhaps the biggest disciplines that use these sorts of data and have learned really smart technical ways around some of these issues. I think learning how we can borrow techniques and tools from these other disciplines to arrive at a stronger conclusion from these data are really going to be quite important moving forward. And that's something that my group is definitely specializing in at this point, because the kinds of data that we have in the US, they're representative of 1% of the population, but then in India, those same data are representative of a completely different portion of the population. And so again, understanding the mechanism of collection, because I think that that's really important here too, and understanding what are the class-related differences in uptake of certain technologies, because this introduces new heterogeneities in terms of the demographics of the individuals who actually are creating the data. And we know that these demographics are also confounded with behaviors that might be more risky behaviors, because individuals may have jobs that don't allow them to, for example, engage in non-pharmaceutical interventions. So all of these things are deeply interconnected. And I think this is where the field of causal inference is really, really useful, actually drawing out causal inference diagrams to understand the creation of your data and to understand who those data are representing is a really big asset and tool in terms of helping us counteract the biases that these data streams introduce. And so that's the component here for, you know, biases. I think for misinformation, I think that's another really interesting area that one of the folks in the Q&A brought up, and I'll just touch on it very briefly. So I think misinformation is quite interesting because the conduits through which misinformation are disseminated varies drastically across countries. And so this is something that, you know, most of my work in misinformation right now is in the United States, and almost you know, a significant chunk, we can't say for sure just how much, but a significant chunk is really, you know, derived from internet-based sources. So certainly while there is propaganda that exists outside of the internet space, in the US, most of this stuff is happening online. So that does really help us in terms of understanding what data are representative of misinformation that's being spread. And the reason for that is misinformation spreads much faster on the internet than it does in meat space. So this is something that's fairly well understood in information science. The speed at which something can travel does vary by the conduit that's used. So that's something to keep in mind as well. And I think that the last thing that I'll say then is that I think that as we build these new data streams and tools to analyze these data streams in higher income countries, the hope is that eventually they will be useful in low and middle income countries as well. So it's this idea that even if things are not fully translatable right now, in 10 years, they may be much more translatable than they are today. And so being prepared for that transition, I think, is enormously important. And keeping in mind that the young people right now all around the world who are very internet savvy all across the world are eventually going to become important decision makers in 10, 15, 20 years, and will have full access to the tools that we're developing in other parts of the world to help engage in digital surveillance for public health crises. I think that's something to keep in mind as well.
Yeah, absolutely. Thanks, Maya. And you know, I think it's getting very clear for everyone participating today through your examples and your experiences that all these advances in the use of data and digital can act as a catalyst, but also can present a number of challenges. I would also say that there are a number of barriers in embracing them as they should or they could be, which leads me to a question that will relate to some questions we had online as well. And maybe Akona, I will start with you. If I was to ask you, you know, if you were to bet on the number one skill that organizations and governments need to acquire to be ready for the next big health challenge, what would it be?
I hoped you wouldn't ask me this question because I'm very biased. I would say epidemiology skills. I mean, everything that Maya spoke about and everything that Helmi spoke about, it's something that epidemiologists understand and truly know when they're going to respond to any pandemic or outbreak. It's something that they have to have at the back of their mind. But moving away from an epidemiologist point of view, I think one thing that we should all invest in is data scientists and really making sure that each government facility has data scientists to help them in terms of the analyzing of the data, as well as ensuring that any technical company that may come with different streams, it can be fully assessed and be able to see whether it actually fits the ecosystem that it's being put into. And so it's quite a number of things for me, though, as well, because I really believe that we still need to invest in data collection itself. In order, because whatever goes into whatever system, there's a huge saying, it's garbage in and garbage out, right? And so if we do not invest in the most basic things, such as ensuring that there are some form of ways to support countries in data collection and collecting the right quality data, we may actually shoot ourselves in the foot by implementing all of these great platforms that cannot really give us the right information that we need.
Great, thanks, Akona. Helmi, what is your one big thing?
Well, for me, one big thing, and having worked across different sector of the government, you know, even the local authority, and there was the security personnel and whatnot, I think one of the biggest skill that they need to adapt is rapid adaptability. You need to have this soft skill of rapid adaptability. The doctors must understand, for example, the public health doctor must be able to appreciate that you can learn from something that you can learn from e-commerce, something that you can learn from people who are doing social media marketing. You cannot, for example, rely on in terms of your risk communication, you can no longer rely on what you learned back in the university, especially for program managers. You must appreciate the fact of social media influencers. Now, for example, they have better reach and their words are more, their words are more impactful as opposed to any doctors or any public health doctors out there in Malaysia. And these are the kind of investment that you need to do, a kind of adaptability or an elastic approach on how you engage the community. After all, despite all of the investment, aside from what Akona was mentioning just now on data collection and whatnot, you can invest in data collection, but when it comes to something that I deploy, then you must also engage the community for them to actually want to contribute their data in the first place. And in so doing, it means the other investment that we need to put forth is in terms of PR and in terms of on marketing pulse as something that need to be owned by the society itself. It's not just a problem of the Ministry of Health. Yeah, so rapid adaptability, I would say so.
Great. Maya, Your one big thing?
Yeah, I think that Akona and Helmi have covered some really excellent points here. And I think that the idea of adaptability and also the creation of data both also are deeply connected with the systems that we're creating to analyze these data. So the thing that I'll add here is that adaptability needs to apply to the systems that are being leveraged to analyze these data as well. So one of the things that I always like to tell my students is, what is your lowest common denominator in terms of the data that is required for your machine to run? And I think that this idea that we need to create machines that can run on a very low data environment and can also run on a very high data environment is one of the next steps that we need to really consider. And I think that gets back to some of what Akona was saying, where we need then data scientists on the other side to understand what these machines actually look like and what is the lowest common denominator in terms of the data that they can consume to produce something that's productive and useful. So I think that that's one of the things that in the interim really does need to happen, because data collection doesn't happen overnight. Rapid adaptability across disciplines doesn't happen overnight, even though these are immensely important kind of disciplinary shifts that we need to see. But I do think that in the interim, one of the things that we can employ is this idea that the systems that we're using to analyze these data, those can be made adaptive in a way that's generally much faster than requiring, say, the disciplinary attitude shift that Helmi is suggesting, which I think is really important, or what Akona is suggesting in terms of collecting better data, which is also immensely important, but these have timescales of probably a decade, whereas creating more adaptive systems have timescales sometimes of a year or less if you have the right data scientists at the helm.
Yeah, that very, very nice and insightful idea of designing for a low common denominator. But now let's talk also a bit. We had some questions about, how to reconcile different cultures, different data format, different interoperability, as many of you have mentioned already today. So let's talk a bit about that, which is probably not the low common denominator, Maya, right? Probably more of a kind of a mid to long-term investment. But so interoperability and patient data exchange are more vital than ever. So what encouraging developments have you seen, and where would you put the focus post-pandemic? Maybe, Akona, we start with you?
That's a very good question in terms of it, because I'm trying to just think of an example within Africa where we can use as an example for interoperability. And there's quite a few examples where we've seen various platforms. I'll use Mom Connect, for example, actually, that was used for maternal health in South Africa. And we've seen that being transformed into use for COVID-19 response. And I think those are the kind of examples of platforms that are really important to consider when we're designing any of these platforms. There needs to be a sense of being able to have that flexibility for them to be interoperable. The other thing is, you don't want to leave a program or a project, a contract ends in the company, and then you are leaving this huge digital platform that no one can use after you have left. And so these are really important things for us to consider when we are designing for the public health institution. This is different from the private space, private sector, where we are making money. But when we are designing for the public health space, interoperability is probably one of the most fundamental things that you want in your program. And this goes all the way to grassroots, because you must also think about who's the end user, who's capturing this information, and how are they going to be able to interact with the system that you are actually giving. And so just speaking towards interoperability, I think probably out of everything else, even if we do not build capacity within government in terms of data scientists, in terms of APs, so long as if you build a system that is interoperable with all the other programs, that will be a success story anywhere you are.
Great, excellent. Maybe a quick word, Helmi, and Maya, about interoperability.
I think, just Akona has mentioned just now, standardization and connectivity has been discussed before, and is actually currently already in the work pipeline of many global organizations. Yeah, among others, the WHO and ITU group for AI in health, of which I am a member of. But prior to that, I think one of the more fundamental things that first need to be settled is been like how health data can equitably be collected, transferred, and analyzed across border as a global public good. And one of the latest report on Broadband Commission that I would like probably all the audience here can then refer to. There was a recent Broadband Commission report on the use of AI in health. Is this important step that countries can take that nationally they can push this forward through the legislation, where they come up with a social contract on data for health. So this is basically a social contract, and the idea is that by default, anonymized data can be collected and analyzed, and people who participate will by default enjoy the progress in medicine and health through it. This is a big jump from how data is being collected at the moment, where for each and every collected data, you need an express consent and you need to tell in advance on how you're going to utilize it. But when it come to innovation, rapid innovation in machine learning, in digital epidemiology, usually in the design time, you don't really have the mind. You're not sure like how it's going to look like and how you can apply those data. So the idea that the Broadband Commission put forth in terms of social contract on data for health is something that is really interesting and worthy of examination. Of course, you must also build into it the ability to for citizens to be able to opt out per their decision. But I believe, at least in the case of Malaysia, it's logistically easier as opposed to the current framework that we have at the moment, where people have to express consent each and every time. Yeah.
Great. Maya, a quick word,
Yeah.
interoperability.
Yeah, I think one thing that I'll add here from the domestic point of view and from the digital contact tracing point of view is that a couple of months ago, Google and Apple joined forces to create a digital contact tracing system that would be interoperable across operating systems. And this was a very novel concept at the time, which I think should give the audience some insight into how difficult it is to get people to play with each other, which I think is really the bottom line when it comes to interoperability being a problem at multiple different scales. I think that who owns the concept and who gets credited for the concept can often play a pretty serious role in terms of the socio-political reasons that interoperability is sometimes not it sometimes doesn't come into effect, even if everybody believes that this should be a priority, that it would make things a lot easier for the purposes that we seek. And I think that trying to examine some of the incentive structures that exist for both corporations and governmental institutions that essentially dissuade them from engaging in interoperable technologies is one of the, I think, very important factors in all of this moving forward, kind of trying to understand what the root causes are. And I do think at the same time, though, and going back to the Google and Apple example here, is that I think that one thing that's happening is that the pandemic is really releasing some of these constraints in a way that we could not have imagined 2 years ago even. So I'm very curious to see how many more of these sorts of partnerships emerge that make the idea of operability easier, because there will be big, large-scale examples of that happening in industry, at least.
Great, excellent. Look, it's been a fascinating discussion. I have to thank all of you for this, and then hand over back to Carissa to wrap up. Many thanks for everyone joining us today and for our three panelists. Carissa, back to you.
Wonderful. Thank you, Bruno. That concludes our first webinar in the new virtual event series. Thank you to our panelists and our moderator for such a wonderful and deeply engaging conversation. We're grateful for your time, as we know how truly valuable it is. To our audience, thank you for joining us. We hope to see you again on Thursday, November 12th for our second webinar focused on sustainable business models for AI and health. Have a wonderful afternoon or evening wherever you are.